Top-Bed Talk.
So this talk really is going to be about optimizing fluid and hemodynamic management during major surgery. So I have some important disclosures. I do some research with Edwards Life Sciences. Importantly, I'm a national PI for a study on automated fluid management, the use of decision support systems around goal-directed therapy. I'm not going to be mentioning that directly in this talk today, but it is, of course, relevant. I'm involved in two societies, the ASA, the American Society for Enhanced Recovery, and the Perioperative Quality Initiative, or POQI. I'm going to be mentioning guidelines by those societies during this talk. And finally, I'm a founding member of the Morpheus Consortium, a consortium between Duke, UCL, and the University of Southampton. So I thought during this talk, I would really answer four major questions. How much fluid should I give perioperatively? Does hypotension matter? Should I use advanced hemodynamic monitoring? And do colloids offer any advantages over crystalloids? And I'm glad to say, when you break this talk down into these four questions, we've had major literature to help answer each of these four questions with high-quality studies published in the New England Journal, JAMA, Anesthesiology, in all four categories over the last few years. And that is in no small part thanks to this meeting, to EBPOM and the work of Monty Mython, really promoting with others fluid and hemodynamic management. And a lot of these studies have come from conversations that have happened at EBPOM and the great fluid debate over the years. So to start off with the first question, how much fluid should I give perioperatively? If you look at this question, there's a well-known U-shaped curve which was first proposed by Bellamy back in 2006, complications on the y-axis, volume load on the bottom. And you can see if your patient's hypovolemic, and again, this obviously makes sense, you can have hypoperfusion, organ dysfunction, and adverse outcomes. And if the patient gets too much fluid, they can get edema, organ dysfunction, and adverse outcomes. And as many of you know, the gut is particularly at risk. And this is really one of the keys of enhanced recovery, to try and look after the gut and prevent GI dysfunction postoperatively. If we get a little bit hypotensive or a little bit hypovolemic, we can get bowel ischemia. So one of the first things you'll do is shut down your splanchnic circulation to maintain your core circulation. Alternatively, if you give too much fluid, you can get bowel wall edema, and again, you'll get that post-op ileus and GI dysfunction, and we'll show you some of the literature shortly. However, one of the things that's been difficult in this area is the terminology has been confusing, and I'll try and clarify some of this during this talk. There's the concept of restrictive versus liberal, but what does that really mean? What is zero balance? And then we have, of course, goal-directed fluid and hemodynamic therapy, but the goals vary from study to study, and again, can be quite confusing to try and interpret. So the first study I'll really look at was the study that really coined the term restrictive. And this is quite an old study now, but it's very important, I think, to go over. And this is by Brigitte Brandstrup, who is a surgeon in Denmark. And this study was published in 2003. I say she was a young surgeon, and she noticed that a lot of her patients were coming out of the operating room quite puffy, and she thought maybe they had a little bit too much fluid and wanted to investigate this. So it was a fairly small randomized controlled trial, and it compared patients getting their standard fluid regime at the time, which was 10 to 12 mils per kilo per hour of fluid, which was, again, fairly standard back in the early 2000s. So their standard patients were coming out 4 kilos heavier, getting 67 litres of fluid on the day of surgery. And she compared this with an inverted commas restrictive regime where they got around 3 litres on the day of surgery with 1 kilo weight gain. And as you can see, there was a massive benefit to their restrictive regime, decrease in complications, both major and minor. However, over the years, this has changed and we've become more and more restrictive. These are two, for instance, ERAS consensus statements that have been put out in the last few years, the bottom one of which I'm listed somewhere in the middle. And you can see the quote in both of these manuscripts was fluid excess leading to perioperative weight gain more than 2.5 kilos should be avoided. And this comes directly from the work of that Brandstrup study and others. However, the second part of the sentence was, and a perioperative near zero balance fluid approach should be preferred. So this is getting much more restrictive. We're not having the 1 to 2 kilos positive that was shown to be beneficial in the Brandstrup study and the avoidance of fluid excess. We're now advocating that we really, really restrict fluid we don't want to have any kind of weight gain, and we're looking to get between 0 and 2 litres of fluid on the day of surgery. And during the enhanced recovery era, when enhanced recovery started, I noticed that people were becoming more and more restrictive, and more manuscripts were calling for a really restrictive approach. And that was advocated in meetings and in the literature. And then we started to see a signal. And this was a manuscript published in the Annals of Surgery. There was another that Monty Mython and Julie Thacker published that was very similar. Looking at big data, and this is from Mass General up in Boston, nearly 100,000 patients. And when they divided the fluid amount given during surgery into 5 quintiles of fluid, they can see that they really mirrored that theoretical U-shaped curve that Bellamy had proposed. In the top there, we see mortality. Yes, there was a signal for giving too much fluid, but there was also a mortality signal on the other end for the patients that had the least amount of fluid. In the middle at the top, as you'd expect, you can see the respiratory complications were highest in patients that had the most fluid. But very importantly, in the top right, we're looking at acute kidney injury, the patients that had that more restrictive fluid regime got significantly more acute kidney injury. So the question became, had we shifted too far and become too restrictive? And then, of course, we had the major study that has been published in this area, fantastic piece of work published by Paul Miles and his group from Melbourne in Australia, the RELIEF trial, and this was published in the New England Journal of Medicine in 2018. And RELIEF was far larger than any previous trial that had looked at restrictive versus liberal fluid therapy, nearly 3,000 patients, major abdominal surgery. And if we look at the fluid amounts, this is where the terminology gets confusing, and I want to just focus on this for a second. Because you can see the liberal group here received 3 litres of crystalloid on average and 500 mils of colloid with about 1 to 2 litres weight gain. So the liberal group in this study pretty much had the same fluid regime as the restrictive group, which was shown to be beneficial in Brandstrup's original study. By contrast, the restrictive group here aimed for a really zero balance approach with about 2 litres of fluid and minimal weight gain. The primary outcome was disability-free survival, and there was no difference. However, there was a signal in terms of acute kidney injury, surgical site infection, and the need for dialysis, with the restrictive group having more complications. So again, the group that had around 3 to 4 litres of fluid seems to be the sweet spot, and the conclusion is a moderately liberal fluid regime is safer than a truly restrictive fluid regime, i.e. we'd shifted too far to being restrictive of our fluids, and we want to basically aim for the patient to get around that 3 litres of fluid to end up 1 to 2 litres positive at the end of surgery. And we'll come back to this later on as we talk about consensus guidelines. So moving on to the second question, does hypotension matter? I mean, obviously a very important question. Why are we having this conversation in 2020 about blood pressure? And I think it's really the era of big data has really accelerated this research. Blood pressure is obviously very important, but before we had big data, we weren't really able to look at hundreds of thousands of patients and really look at the impact of blood pressure on outcomes. Over the last few years, obviously, we've been able to get big data through electronic healthcare records, and the Cleveland Clinic has really led the way in publishing a number of studies on hypotension and outcomes. This is one of the studies that they published, again, looking at around nearly 60,000 patients, are comparing the lowest blood pressure with outcomes such as postoperative acute kidney injury and also MINS, myocardial injury after non-cardiac surgery. And the results were very interesting. You can see this is a logarithmic scale on the y-axis, but there's a clear inflection point for both AKI and MINS that when your lowest MAP is below 65, significant upturn in both acute kidney injury and MINS. This occurs even if it's just 1 minute of hypotension, and obviously as the duration of hypotension increases, you can see the slope of the graph increases as well. Importantly, 1/3 of these hypotensive events were between induction of anesthesia and incision, and we know the patient's at risk of hypotension during this time, and obviously we can't blame the surgeon. That's us, that's our induction of anesthesia. And since this data has started to come out, I've changed my practice and been much more vigilant about trying to avoid hypotension at all times during surgery. Obviously, this is just an association. Sicker patients are more likely to get hypotensive. Sicker patients are more likely to have adverse outcomes. Nevertheless, it's a powerful association. It's been shown in a number of studies, and I think, along with some other literature that I'll show you in a second, I think it is enough to make us really think about our practice. So from this work from the Cleveland Clinic came the only so far prospective study looking at interventions in terms of blood pressure to see whether they change outcomes. So this study published in JAMA, which is impressive for a 300-patient study. And this study was from France, Emmanuel Futora and colleagues, looking at these 300 patients, comparing an individual blood pressure management strategy versus control. Again, it's important to look at the details here. The individual blood pressure management strategy, all these patients had goal-directed fluid therapy. All of these patients had at least 2 fluid bolus to optimize their fluid status, and then they had a peripheral norepinephrine infusion to maintain systolic blood pressure within 10% of normal. So again, if we just highlight the details there, they were filled first, they had volume first, and then squeezed to maintain blood pressure, and we'll come back to that later. They did that intraoperatively and for 4 hours postoperatively. And the control group had ephedrine boluses to maintain their systolic pressure greater than 80. And you can see significant reduction in postoperative organ dysfunction with the individualized blood pressure control group. Very interesting study, needs repeating, of course, but again hints that optimizing fluid status first and then blood pressure can improve outcomes. So the Perioperative Quality Initiative that I'm very involved with, amongst others, at EBPOM, had a conference in 2017 when we reviewed a lot of this literature, and we published 4 manuscripts, all about blood pressure, published in the May 2019 edition of the BJA, including some cover art that you can see here. So we reviewed this literature, and the consensus statement that was published in the intraoperative manuscript was intraoperative mean arterial blood pressure below 60 to 70, and we chose 60 to 70 because some of the studies have looked at 60, some 65, some 70, so a little bit of a range, is associated with myocardial injury, acute kidney injury, and death. Systolic arterial pressure below 100 is also associated with myocardial injury and death, and again, there is a study that particularly looked at systolic pressure, and injury as a function of hypotension severity and duration. So again, looking at the available literature, this is the statement that this group of experts came out with and has been published. A couple of important caveats at the bottom there. There is evidence that hypotension is associated with tachycardia, with tachycardia enhances the risk. And very importantly, I think the last statement, for patients with preoperative hypertension, the threshold at which harm occurs may be higher. So a lot of these big data is not granular enough to look at patients with preoperative hypertension. But I think we all intuitively think we may want to keep the mean higher than 65 in those patients, and that's why we really wanted this statement to come into the manuscript. So moving on to our third question, should I use advanced hemodynamic monitoring? So should I use a cardiac output monitor to optimize stroke volume? And we know there's been a number of studies over the years that have used this approach. Typically, we'll hook up a cardiac output monitor and give fluid boluses, as you can see on the bottom left there, to optimize patients on their Starling curve, looking at 10% changes in stroke volume. And in the middle here is a meta-analysis published in 2011. Almost every study was to the left of the line, showing benefit of goal-directed therapy over control, a halving of complications, and we wrote the accompanying editorial to this meta-analysis suggesting that goal-directed therapy should be used for all patients undergoing major surgery. However, it's important to note that this was in 2011 and the majority of these studies were published in the early 2000s. The majority was small, single-center studies, very much done in the era before any enhanced recovery. So what I really like to concentrate on is the fact that the world changes quickly. In 2002, 2003, using this analogy, we were having some brick of a phone that we were carrying around with us, and it's really in no way comparable to the way we live our lives and the workflow we have with the smartphones today. And I think it's relevant because the world in 2001, 2002 was very different to the world we live in terms of major surgery. So the question we have to answer now is, does goal-directed therapy offer any advantage over a sensible fluid protocol within an enhanced recovery pathway? So we've evolved a lot over the last 15 years. And we're starting to see trials now that are showing no benefit. And this is one. This was published from the group in McGill. I just like to look at it for a second. This was published in Anesthesiology in 2017. Say the primary outcome, no difference in post-op ileus, no difference in length of stay, no difference in complications. However, when you look at this study, you can see it's a small single-center study, 64 patients in each group, within an established enhanced recovery pathway, all laparoscopic surgery, mainly ASA2s, and patients on average were ready for discharge on post-op day 3. So when we're getting this kind of practice, it's not surprising that goal-directed therapy, when added to this mix, is not going to show any additional benefit. So I really like this editorial by the now retired Jonathan Wilson and Gary Minto, The Great Fluid Debate, Time for Flexit. Flexit is fluid exit, and this is obviously play on the term Brexit, which, tongue-in-cheek, some of you may remember, was in the news a couple of times in the pre-coronavirus era. And when they call for Flexit, they basically say two things. One, we should stop giving too much fluid. I think we'd all agree. And secondly, we should stop performing and publishing small, conflicting efficacy trials and pool our resources to perform definitive effectiveness ones, i.e. we need large, pragmatic trials to really try and answer this question, not more single-center studies. And I couldn't agree more. Unfortunately, we're starting down this road. So the first major randomized, multi-center randomized controlled trial looking at this area was the Optimize study, again, published in JAMA. Tremendous piece of work by Rupert Pierce and colleagues attempting to be the definitive study in this area. Unfortunately, as many of you know, it wasn't quite. So we look at the two groups. You can see that the intervention group, the group that had goal-directed therapy, you can see the curves clearly separating, less cumulative mortality, the primary outcome less within the intervention group compared to usual care. However, unfortunately, the study was slightly underpowered. The outcomes were less than they anticipated when they powered the study. So even though the curves separated, it didn't quite reach statistical significance, with a trialist's worst nightmare of a p-value of 0.07. So again, a hint at benefit with goal-directed therapy, particularly in medium to high-risk patients in this multi-center study, but not quite statistical significance. The next major randomized controlled trial that was published was the Fedora study, and this was published in the BJA in 2018. And importantly, just to dwell on this protocol for a second, so what they did in this protocol, again, multi-center study, over 400 patients, is they optimized fluids first with fluid boluses, and then in patients that were still hypotensive, they added a vasopressor. And if you remember the study that was labeled as an interventional study on blood pressure, Futura's study, they optimized fluid first and then squeezed with vasopressors. So it's one study is a blood pressure study, one study is a goal-directed therapy study. The actual protocol was very similar. And this is the message I think I'd like to get across. Benefit from optimizing fluids first, and then a lot of patients adding a vasopressor if they're still hypotensive. At the bottom right there, you can see that if the patient had a low cardiac index, you could add an inotrope. And this was recommended, but it only occurred in 3% of patients. So the majority of patients, fluid, and then about half the patients needed vasopressors. And again, they saw a reduction in complications and length of stay with this approach. And finally, two upcoming studies, which are hopefully really going to answer this question. Optimize 2 is underway. It's been recruiting for a few years. 3 times the size of Optimize, 2,500 patients, large, pragmatic study comparing goal-directed therapy with fluid and inotropes for intraoperatively and 4 hours postoperatively with control. And again, hopefully this study will be definitive in this area. And secondly, Floella, a fantastic piece of work by Mark Edwards and colleagues, looking to recruit 7,500 patients in emergency laparotomy. Again, this is underway and has been recruiting very well, and we look forward to the results in a few years. So where are we now? I've presented a lot of data, and Paul Miles and myself published this sort of updated risk-adapted matrix in Anesthesiology last year, and this is where I believe we are now. So we have surgical risk on the y-axis, patient risk across the bottom. So in those low-risk patients, similar to the study that was published in Anesthesiology, relatively healthy patients, laparoscopic surgery, I don't think you need goal-directed therapy. Just aim for 1 to 2 litres positive following the results of the relief study. As surgical or patient risk goes up, again, we still want to aim for 1 to 2 litres positive, and we recommend individualised goal-directed therapy. You may say, well, if you're doing goal-directed therapy, why are we still aiming for 1 to 2 litres positive? And I think my answer is that I think, even within doing goal-directed therapy, you still have many grey zones. You have a patient that has a little bit, their stroke volume drops a little bit, they're a little bit hypotensive, and you're debating to yourself whether you want to give a fluid bolus or not. I think it's useful to have an end goal in mind, to have a target. If the patient's perhaps only 500 mils positive, at that point you may decide to go ahead and give that fluid bolus. And finally, of course, the highest risk patients, again, goal-directed therapy and postoperative surgical intensive care. And this really mirrors the POCI guidelines as well that were published a few years earlier in perioperative medicine. And again, this was a hemodynamic framework looking at point number 1, is there a clinical problem? Try and define the problem. Use your advanced hemodynamic monitors in those high-risk patients. Point number 2 is that sort of pink blobby structure, which is meant to be a brain. So engage our brain. There's still some use for the clinicians. And again, fluids first, and then squeeze if necessary if the patient's still hypotensive. And finally, the last question on the list, do colloids offer any advantages over crystalloids? This is the the largest study looking at this question, published in Anesthesiology last year from the Cleveland Clinic group. Multi-center trial, over 1,000 patients in major abdominal surgery with a background crystalloid infusion, 3 to 5 mils per kilo per hour, and then goal-directed therapy using boluses of either a starch or a crystalloid. And you can see both groups had about the recommended amount of fluid following the relief study, 3 litres of crystalloid versus 2 litres of crystalloid and a litre of colloid. Absolutely no difference in complications, length of stay, or renal outcomes. And finally, there's one study which was just again published a couple of years ago, which teases a little bit of a benefit for colloids. This is using the closed loop system, the automated use of decision support to do goal-directed therapy. Much smaller, 160 patients. Background crystalloid infusion again and again, colloids or crystalloids for boluses using the closed loop system, so using the computers. And in this study, there was a benefit of colloids over crystalloids, a reduction in complications and a reduction in total fluid volume. So to conclude, I think these are my summary points. I think when we do our fluid management in low-risk patients, I think we should aim for 1 to 2 litres positive, as illustrated in that risk-adaptive matrix. For high-risk patients, individualised goal-directed hemodynamic therapy, so fluid first, then vasopressors, aiming for 1 to 2 litres positive. So fill the tank at first, then squeeze. I think I've said that a few times now. Maintain our mean blood pressure greater than 65 and potentially higher in patients with pre-existing hypertension. And someone who's always used colloids, I think I have to accept now that the evidence of any benefit from colloid therapy is currently weak. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.